Okay, guys, I'm going to pick up from where I left off. I'm going to make this a very short promise, a very short video, something you can watch quickly throughout your day. I'm on page 105. This is going to be covering the PA projection of the chest x-ray along with the lateral. Both of those are normally protocol routine. Your PA and your lateral chest x-rays are done for the 90 degrees. Two images at 90 degrees apart from each other. So for the PA breathing instructions for the, I'm on page 105, they talk about, let me go ahead and share this PowerPoint, but what it talks about is actually the breathing instruction and what happens when we're actually giving our patient our breathing instructions. So this image here, just I think you've probably already seen it. It's from your book. Little guys, that's on page 107, proper positioning. I think the other image actually came from the the edition before the one you have. But under breathing instructions on page 105, it says, during normal inspiration, the costal muscles, that meaning ribs, pull the anterior ribs superiorly and laterally. The shoulders rise and the thorax expands from front to back and from side to side. Deep inspiration causes the diaphragm to move inferiorly, resulting in elongation of the heart. Radiographs of the heart should be obtained at the end of normal inspiration to prevent distortion. So if you were actually doing what they call a cardiac series, you would not want to overinflate the lungs with the double inspiration instructions. You would only want to do it on inspiration only, not the double inspiration. It says when you have a pneumothorax, which I showed you a picture of that in the last video. A pneumothorax is simply air that has escaped out of the lung cavity itself. Remember, the pleural cavity is two different linings, and that air has gotten trapped underneath that bottom line, that visceral lining of the inside and outside of the lung organ itself, so it's trapped. And that's called a pneumothorax. So it's free air in the thoracic cavity. It's outside of the lung cavity itself. So it says if you're suspecting a pneumothorax, it's expected. Normally we do one exposure is often made at the end of full inspiration, and you'll take another one at expiration. And this will help you to determine if you see any small amounts of free air in the pleural cavity that might be obscured by the inspiration exposure. Inspiration and expiration radiographs are also used to show the movement of the diaphragm. There's actually a procedure called a sniff test that we do in fluoroscopy, where they watch the diaphragm under fluoroscopy, and they have the patient actually sniff like that, and you can see if you have a paralyzed diaphragm, it doesn't move, but as you sniff like that, it actually jumps up and down. But that's just extra information for you. So technical procedures on that middle column on page 105, it's got the PA projection of the chest is the most common projection, which I've already said, and it is used for all lung and heart examinations. The lateral projection is usually ordered in conjunction with the PA. So for your comp on a chest x-ray, a routine chest x-ray, you're going to be doing the minimum projections on the PA and then a lateral. The exposure factors and accessories employed in examining the thoracic viscera depend on the radiographic characteristics of the individual patient's pathological condition. Normally, chest x-rays are done with the use of very high KVP. The appropriate KVP will penetrate the mediastinum. Remember, that's the middle part of the chest cavity, the thoracic cavity. You have the lungs, left and right, and in the middle you have the mediastinum. The middle, or if you want to call it the hilar region, would be good also. The appropriate KVP will penetrate the mediastinum to show a faint image of the spine, as well as demonstrate the pulmonary vascular markings. Remember, we talked about the lung markings in the lung field. That's when you know you have made a good exposure. Kind of go along the same idea when you were doing bone working, where you're looking for that bony trabecular pattern. So it's the same idea. that we're talking about here, but it's called vascular markings within the lung field itself. When you can't see that, your exposure was not correct, or there may be a pathological condition that's obscuring that view. Over on page 105, again at the top of the third column, it talks about the SID of it says the source to image receptor distance of 72 inches should be used to do two things: minimize magnification of the heart, and also to gain greater spatial resolution. You need to remember that we're doing the PHS at a standard 72 inches, a high KVP, which is normally at 110 or 120. The 72 inches is to help reduce cardiac magnification and also to improve spatial detail. Okay, so keep that in mind. The next section talks about radiation protection. It says shield gonad statement indicates that the patient is to be protected from unnecessary radiation by restricting the radiation beam, using proper collimation first, and then, as you can tell in this little image here, let me get my little pencil going again. I kind of like that little laser pointer. So again, you can see the little guy here. He's got a purple apron on, draped over on, hanging on his waist. So that's your second type of shielding, and you also can see the clean collimation square around him. That's going to help reduce his exposure also. So for radiation protection on the PHS, you definitely want it. Your first defense is going to be for a good collimation, and we'll get to the dimensions of that in just a second. And also to always drape a shield on the bottom hanging from the waistline. Okay, I'm turning it over on page 107, and we're going to talk a little bit about the actual procedure itself. PA projection on your image receptor plus a grid. It says that the central CR plate is usually 14 by 17, lengthwise or crosswise. That is a CR plate. Remember, you will be going into a DR world where there are no longer plates that you will actually physically go get. So the dimension you'll probably be working with is the fixed 17 by 17. So you don't have that to really worry about when you're doing the chest x-ray. It can only go on there one way, whereas when in that first video I was talking to you about body habitus, and we had to be cognitive of the body habitus and what we thought the lungs would look like in every patient. So we would put our IR in there in the correct direction, either lengthwise or crosswise. This still is true with your CR, but with the new DR equipment, which 95% of our clinical sites, if not more, have DR now. So you're going to be dealing with a 17 by 17 inch square. So your job is to actually get good collimation on that and not keep it open for the complete size of the DR plate. Again, on page 107, it talks about your SID, minimum SID of 72 inches. Again, it has two purposes: magnification of the heart and increased recorded detail of the thoracic structures. You're looking at those lung markings, vascular markings in the lungs. You want to be able to see that. Remember, that's kind of like a network, and you're looking to see if you can see that in all areas of the chest. If you can't see it, then again, you have some underexposure, and honestly, it's not going to be a problem with your DR world because of the computer being able to actually help change your window level and window width, so you're able to really be able to play around with that, or technologists or the radiologists, in order to see all these different areas and tiny details within the lung cavity itself. Position of the patient, it says, if possible, always examine the patient in the upright, always. Now, upright can mean standing. It can mean sitting on a stool facing the vertical, as long as their chest field is still vertical, it's still up. That's considered erect. Okay, it says so that the diaphragm is at its lowest level and any air or fluid levels will be seen. By having a patient stand up, the pressure of the abdomen is released, so you do not have engorgement of the pulmonary vessels is also avoided. Patients sit on a stretcher. Being done on a stretcher can actually be, we do this a lot at one of our main clinical sites. We actually, even if they're on a stretcher, we sit them straight up vertically in their bed, and that's still considered erect. Remember, we always want to do our chest x-rays as erect as possible because we're looking for minute little areas that, like the costophrenic corners, that may have a little bit of fluid in it, and you're not going to see that if the patient's not fully erect. So keep that in mind. Position of the part, it says have the patient with the patient standing with the arms hanging at the side against the vertical device. Adjust the IR so that its upper border is about 1.5, 1.5 to 2 inches above the shoulders. Center the mid-sagittal plane of the patient's body to the midline of the IR. And again, you can see this is where they're talking about. This is your MSP. Right over the spine, you can just run your finger across their back and you can center them up perfectly because those little bumps on the back right there as you run are called spinous processes coming off of your vertebral bodies. Again, we're going to adjust it so we have a 1.5 to 2 inches of light up here above his shoulders. You can see the light up the shadow of his shoulders right here where the marker's at. And you can also see that light field. That's what we're after. Center mid-sagittal, we've done that. Have the patient stand straight, support and equal distribute his weight or their weight is going to be important. We don't want them to favor one side or the other because we're trying to get them square on that board. So have them separate their feet just a little bit and just kind of stand normally to where their weight is equally distributed. Extend the patient's chin upward. We talked about this right in here. I don't know if you can see that. But there's a little notch up here where you're supposed to have their chin. This guy here looks like he can tolerate it. This little guy here, it really looks like it's really stretching his neck. And I prefer not to do this to my patients. I'll have them just back out of that little cut groove there and just say, just look forward so that this back part of the occipital of the skull is not going to be obscuring anything that you need to see as far as a chest x-ray. Okay, but it does say have the patient's chin upward and over the top of the grid device, and adjust the head so the mid-sagittal is vertical. Ask the patient to flex the elbows. We have the elbows flexed and the back of the hands low on the hip, low on the hip. This is done for a reason. Depress the shoulders and adjust them to lie in the same transverse plane. These movements will position the clavicles below the apices of the lungs. Rotate the shoulder. Now, we've already depressed them. We've already pushed down on his shoulders. Now we're going to have him rotate the shoulders forward so that both of the shoulders touch the vertical device. And what this is going to do, this turning of the humors towards the IR, it's going to take the scapula and it's going to pull it off the lung field laterally. That's the most important thing, and that's the one thing we always look at when we're looking at student images. This movement will rotate the scapula outward and laterally to reduce superimposition of the scapula with the lung field. Over on page 107, on the third column, we've already discussed it. I showed you some images of women with female breasts that are large enough to be superimposed over the lower part of the lung field, especially the what? Costophrenic angles. We ask the patient to pull the breast upward and laterally. This is especially important when ruling out the presence of fluid. And guys, you'll have to get used to doing it. It's a medical procedure. It's nothing to be, to laugh about. It's nothing to be ashamed of or embarrassed. But this is something very important. You can even explain to the patient why this is necessary. Because we don't want breast tissue to look like a disease process. And we also don't want breast tissue to obscure any of the possibility of having any type of pathological condition. Okay, it says this is especially important when ruling out the presence of fluid. Have the patient hold the breast in place by leaning against the IR. Again, your gonad shielding should be a lead shield between the x-ray tube and the patient's pelvis. Your respiration, on page 108, full inspiration, full. This exposure is made after the second full inspiration to ensure the maximum expansion of the lungs. the second. Again, this is something you can be talking about as you're positioning this patient. I'm telling this guy here, all right, sir, in just a minute, I'm going to get you to take a breath, blow it out, and take in a much deeper breath. As I'm positioning, do you understand? Yes. So as I'm walking away, I say, go ahead and blow that air out. Now take in a second, much deeper breath and hold. And that's going to help over expand the lungs so that we are really getting a good picture of them. Excuse me. The exposure is made after the second full inspiration to ensure the maximum expansion of the lungs. The lungs expand transversely, anterior, posteriorly, and vertically, with vertical being the greatest dimension. So that's what we want. We want to expand those lungs in all dimensions that they can. For certain conditions, such as a pneumothorax or the presence of foreign body, radiographs are sometimes made at the end of full inspiration and expiration, and we said that earlier. And the one thing I want you to do, I want you to go back on page 88, and I want you to read on the right main bronchi, the way that it is situated and the way that it bifurcates off of the trachea. It says that it bifurcates higher, it's wider and shorter. So, excuse me. So if you're going to aspirate or swallow something, get choked on it like I just did, and it gets lodged in your trachea, it's more than likely going to get moved to the right bronchi. So I want you to know that. I've said that, and I'm telling you to go back on page 88 in your book and read on it. And it actually tells you this, that the most likely place for a foreign object in the lung fields is going to lodge into the right main bronchi. So back on page 108, pneumothorax is shown more clearly on expiration because collapse of the lung is accentuated. So when you get a pneumothorax and that air starts accumulating outside of the lung and it has nowhere to go, well, guess what it does? The air continues to escape and it's taking up the space where the lungs are supposed to be. So that free air starts pushing down on your lungs, actually causing the lungs to completely collapse. Excuse me, goodness. All right, so I'm over on page 109. Central ray is perpendicular to the IR. The central ray should enter at the level of T7. T7 is going to be at the what? Inferior angle of the scapula. You got a little triangular bone here. It's right there. You're going to feel it. You're going to feel that medial border, and then at the very inferior angle, that's where you're going to put your horizontal line. Collimation, it says 17 inches lengthwise and 1 inch beyond the lateral shoulders. So you're going to keep it from the lateral shoulders here. You want to keep it 1 inch in, and you want to keep it 17 inches open top to bottom, but you bring it into 1 inch to the shadow of the patient. Let's see, structure shown. Let me see if I got the next slide. What we got going on here? Why is it not projected? Okay. Structure shown. PA projection of the thoracic viscera show the air-filled trachea. Right there, guys. You can barely see it, but I can see it going right there. And there it is again. So there's your carina. Okay, it says the lungs, the diaphragmatic domes. Here's your domes. The heart, here's your aortic arch. There's your heart. If enlarged laterally, the thyroid or thalamus gland, not going to really see that because that's going to be higher up in the neck, but if it's enlarged, you probably could. The bronchial trees, everybody see the lung markings, the bronchial trees, all the little white vessels. That's what we're looking at, the vascular markings in the lung field. They call it the bronchial tree is shown from an oblique angle. The esophagus is well shown when it is filled with barium sulfate. Of course, we don't have any barium sulfate on this image. Evidence of proper collimation, presence of a marker. I'm not seeing a marker. I see a marker on this one. Okay. Internal lungs with the apices to the costophrenic angles. Here's your apical areas here. They're fine. Costophrenic angles are clean. They're fine. They're demonstrated. No rotation. Remember, we looked at the sternal rotation, and I think that it shows really well here. You can see these little dots right here called your pedicles of the spine. You have equidistance right there to right there. So this looks really good. This does not look rotated at all. This one here looks pretty good. I see a joint space, and I see a joint space. So I know that the clavicular ends, the sternal end of the clavicle has not been rotated over on the spine. The trachea visible in the midline. A little light on this one here. I would say it's right there. But here you can definitely see the gray, the darkness of the air right there. Equal distance from the vertebral column to the lateral border of the ribs. So you're just looking for this here. Equal amount of body from the middle of the spine to the outside lateral border of the ribs. Proper anterior shoulder rotation demonstrates the scapula projected outside of the lung field. Here we can definitely see that's the margin of it right there. You can actually almost see it going into what we call the scapula Y. Y'all remember that? There it is right there. Here's the thickest border. That thick border is which one? That's on that outside edge. And here's your very thin border right there. Again, you can see the top, the scapular spine right there. I don't see it really superimposing this one. I do see a problem here with the, you see this was the one you looked at on that last video. It was the breast issue overcoming the costophrenic angles, but with the breast in place and they're lifted and separated, you can get these costophrenic angles cleared. Short outline of the heart and the diaphragm. We've seen all that. Here's your diaphragm. Here's your heart. So overall, pulmonary vascular markings from the hilar regions to the periphery of the lung. So you need to be able to see this from the hilar region. This is the hilar region of each lung. There's the busy part there. It's where all your ins and outs, all your blood vessels enter the all your veins. And you can see it all the way out to even the peripheral edges of this chest x-ray. You can see these tiny little white lines. So you have very good detail on that one. And that was on page 109. All right, so now we're going to talk about the, well, this is the one we looked at already on that other slide. I threw it back in on this short one here. You're looking for rotation. We have equidistance. Both joint spaces are open, no problems there. There's your, the clavicles are below the apex. There's the superior spine of the scapula. The border of the scapula looks like it's pulled all the way out. I'm saying it is because I see it right there and then it comes down. Same thing there. You can see it's pulled out on this one. This one's pretty good. Can you see that faint line right there? It could have been pulled a little bit better on this one. And the problem with this one is that we actually have rotation. And the reason we have the rotation is that this joint is actually rolled over. So this person has kind of rotated, got his right side kind of rotated and causing the left to be pulled away. The right side is rolling over onto the spine. Hope everybody understands that. Okay, and I think we're going to get into our lateral. This is on page 110. Lateral projection, positioned by manufacturer or department protocol for proper anatomy display orientation. CR plate 14 by 17. If you're still doing CR, it's going to be the same thing as if we talked about with the PA. Same thing with the minimum distance. And we're also doing a left lateral as protocol because what's on the left side of the chest, the heart closer to the IR is going to help reduce magnification. We're also going to do our laterals at 72 inches, which is going to give us better spatial resolution, less cardiac magnification. And that's on page 110. Upright diaphragm is at the lowest. Everything, engorgement of the blood vessels, all that under position of patient is the same for the PA. Turn the patient in a true lateral position with the arms by their side. Okay, to show the heart and lung, left lung, use the left lateral. Obviously, that's what you're going to be doing. Position with the patient's left side against the IR. Position of the part Adjust the midline. The mid-sagittal plane of the body is parallel. This is the mid-sagittal over here, right? If we had a plane cutting through, mid-sagittal would be what? Parallel. And the adjacent shoulder is touching. So he's got his left shoulder touching. The mid-coronal plane should be perpendicular. Here's the plane. We had a piece of cardboard slicing straight through him. It would be perpendicular to the IR. And if we had one slicing through right here, a piece of cardboard stabbed through his MSP, it would be parallel to the IR. Have the patient extend the arms directly up, flex the elbows and forearms resting on the head. Hold the arms in position. And guys, a lot of people do this. I've seen lots of other techs and senior techs do different things. You'll see this in different clinical settings. Just go with whatever they're saying. The biggest point is to get this humeral heads up and out the apices of the lungs. That's our biggest thing that we want to get accomplished. So let's see where we're at. It says, and once you've done that, having their flex the elbows, place an intravenous catheter stand in front of an unsteady patient. You could actually have them hold an IV poke real high. Get them and extend the arms out if they're unsteady. Some of our rooms actually have bars that they can hold. So it's just getting the shoulders up is what we're after. It's just the IR height. It's the same. It's 1.5 to 2 inches above the shoulders. Recheck the position of the body. The mid-sagittal plane must be vertical. The mid-sagittal plane must be vertical. And that's, again, if you were to slice this guy and put a piece of cardboard right there straight into him, it would have to be perfectly vertical. It can't be slanted either way. Shoulders can't be tilted in. Hips can't be pushed into the IR. Depending on the width of the shoulders, the lower part of the thorax and hips may be at a greater distance from the IR. This is what I was talking about. But for the body position is necessary for a true lateral. Having the patient lean against the grid device, foreshortening, results in distortion. All of the thoracic structures. Forward bending also results in distorted structural outlines. We've seen that earlier in that first video. I think I have it on this one also. The respiration is going to be the same as we did with the PA. Full inspiration. The exposure is made after the second full inspiration to ensure the maximum expansion of the lungs. Same thing as the PA, guys. Same central ray is going to enter at the same point. So now our horizontal line, you're going to feel on his back. You're going to feel the bottom of that tip of the scapula. And also remember that's T7, inferior tip of the scapula, T7, and also lines up with the nipple line. So we have inferior angle of the scapula, T7, and we also have it in the front, we have the nipple line. And obviously this vertical part of your crosshair is going to be on the MCP, mid-coronal plane. Respiration, we've talked about central ray, we've talked about collimation. Again, adjust radiation field to 17 inches lengthwise. And then you're going to start collimating it anterior to posterior. I think it says 1 inch. Yeah, 1 inch beyond the anterior and posterior shadows, but no more than 14 inches. So that one don't get too tight, but you still got to collimate it in from front to back. Structure shown, the primary left chest portion is used to show the heart, the aorta, and the left sided pulmonary lesions. These lateral projections are employed extensively to show the interlobular fissures. Remember, we had the right one had that horizontal fissure, and it cut the lung. They had 3 actual lobes, and the left side did not, but they did have different sections. So the right has 3 lobes. So that's what they're looking at, so they can determine what, if they have any pathology, what lobe of the what side and what lobe is it has the pathology gotten into. Excuse me. Okay, evaluation criteria. Let me go to the next one. This is that leaning and bending. This is on page 111. Obviously, the leaning part is going to give you some foreshortening. This is just a distortion, so we want the patient to be perfectly standing straight, not to lean back. And they have a tendency as they put their arms up, they kind of want to do this. And then you try to overdo that, and they're leaning forward. Remember, we want them to stand straight up. Um, let's see, evaluation criteria. Let me go to the next one. This is still on page 111. Evidence of proper collimation, 1 inch front and back, and we want to keep it open 17 inches top to bottom. The arm or its soft tissue not overlapping. See how the arms are not overlapping the apex? Well, look here. There is your what? Air-filled trachea. There's your esophagus, got a little air in it. There's one of your main bronchi on in. Remember, we're looking into it, into that tube, into that bronchial, because it's a tube. We're looking in it from the lateral side, so we're looking in like it's a straw. Costophrenic angles and the portions of the pulmonary apices are not obstructed. Apices, costophrenic angles cleared, no problems. The hilar is at the appropriate center of the radiograph. This is the hilar region right here. That's the carina. That's where all your vessels are at, right there in the middle. Superimposition of the ribs posterior. This is perfect. Very, very, very little. I see a little bit of rotation there, but this is, I mean, almost textbook perfect. Obviously, it wasn't a textbook, but this is what you're shooting for, guys. And again, you want that sternum completely free. You don't want any lung filled over it. It's really a beautiful lateral. The sternum is in clean and it's in profile. You can see the sections of it. See right there, the manubrium. See that? There's a xiphoid. Trachea visible in the midline. There it is. Open thoracic intervertebral. Y'all see the joint spaces are open. Here's your intervertebral foramina. The little holes back here are completely open. Sharp outline of the heart and diaphragm. So that's the lateral and that's the evaluation. The AP chest is on page 119. Going to do it real quick. Okay, supine position is used when the patient is too ill to sit or stand. The upright position is used for patients in wheelchairs who cannot stand and must remain in the wheelchair. Okay, so you can do it upright in a wheelchair. That's still considered upright. This is going to be the one that we're going to have a problem with. You should never really be doing an AP chest flat. There's just no reason for that. But again, if they're that sick and if they're in ICU or something and they cannot be moved other than laying flat, then you just have to go with it. The upright position is used for patients in wheelchairs who cannot remain in the wheelchair. In addition, patients on a stretcher can be radiographed sitting up. So we still want to go with that idea that all chest x-rays are done erect, unless contraindicated for some other medical issue. We still want to, even inpatients in their rooms, we get their bed to come up. We sit them up as high as they can. Go. Anything is better than doing a flat chest x-ray. Everything's going to stay the same with your CR plate. You can do 14 by 17 lengthwise or crosswise. Your SID. Try to get your SID if you can. Obviously, when they're on a radiographic table, it's hard to get your 72 inches if even possible. So that's going to be a problem. If I were to do this, I'd leave the patient on the stretcher and get my SID that way. I don't see any reason sliding them over and getting them on an x-ray table. If you're going to do them AP supine, why not just do it in their hospital bed or gurney? So that would be my reasoning for a shorter SID may be required depending on the equipment and space available. This is 119, bottom of the column, SID. Place the patient in the supine or upright position with the back against the grid. Everything stays the same, guys. Mid-sagittal plane of the chest to the IR with the upper border. You still need light above the shoulders, 1.5 inches to 2 inches of light above the shoulders. The patient condition allows flex in the patient's elbows, pronate the hands and place them on the hip. I don't think he's got his done that way, but that would help pull the scapula laterally. Full inspiration, the same respiration. Central ray is going to be perpendicular to the long axis of the sternum. The central ray should enter about 3 inches below the jugular notch. 3 inches below the jugular notch. This is a little bit different than the T7 at the nipple line. So we're going to go 3 inches below the jugular notch. So you can put your finger up there and feel the little soft spot. That's your jugular notch right there. So you want to go a little bit below that when you're doing an AP supine, and I would think it has a lot to do with the SID. Let's see if I got another slide. Okay, AP and PA to cube is on 125. This is done when a person cannot be done erect and you're looking for air fluid level lines, guys. This is a specialty view. It's on right lateral, left lateral, depending on, we normally do the left, but if they tell us that they suspect there's fluid on the right side, that's the side we want to get down. So for the chest to cubes, we want side down. Wherever we're suspecting there's fluid, because what's going to gravitate down when a patient is in this decubitous position. And remember, for a decube, your plate is going to be vertical and your central ray or your x-ray beam itself is going to be horizontal to the floor. Okay? Place the patient in a lateral decubitous position lying on either the affected or the unaffected side as indicated by the existing condition. A small amount of fluid in the pleural cavity or pleural effusion is usually best shown with the patient lying on the affected side. Pleural effusion means that there is fluid in the lungs. With this position, the mediastinum shadow and the fluid do not overlap. A small amount of free air in the pleural cavity, a pneumothorax, is generally best shown with the patient lying on the unaffected side. If you suspect that there's free air in this guy's chest, you want to put the suspected side that he has free air, you want to put it up here, because guess what? Air outside of the lung, the pleural cavity, it's going to rise. So there's going to be a line of air up here. So if you're looking for a free air, it's going to be the affected side up. If you're looking for fluid, it's going to be the affected side down. Exercise care to ensure that the patient does not fall off the cart. If the cart is used, lock all wheels. That's if you're doing this in the ER and you're keeping them on the bed, which I would be doing this at the vertical with the patient on a bed, scooting them all the way to the side and using the bucky tray instead of this setup here. Achieve the best visualization by allowing the patient to remain in the position for about 5 minutes before the exposure. Lots of time, the fluid that's in these guys with pneumonia, it's a very viscous, very thick fluid. So you want it to have time to actually gravitate down and level off so you can see it. So if they can, we like for them to stay on their side for a couple of minutes. And honestly, we get them on their side about time we've set everything else up. They've been on their side long enough for that fluid to accumulate down to the bottom. It says this allows fluid to settle and air to rise. That's on page 125. Okay, this is the patient is lying on the affected side to demonstrate the presence of pleural effusion. That's fluid. Elevate the body 2 to 3 inches on a suitable platform or a firm table. In other words, if you're trying to get this side here, you need to lift this side up. So he needs to be laying on a sponge or leave him on his bed and push this down below the mattress, because we need to make sure that that little bit of fluid is not going to get covered up by a skin fold or anything else. We need to elevate this side. Extend the arms well above the head and adjust the thorax in a true lateral position. The same thing, 1.5 to 2 inches beyond the shoulders. Full inspiration. The second exposure made after the second full inspiration to ensure. So this one also has a double breathe, second breath, full inhalation. Horizontal and perpendicular to the center of the aura at the level of 3 inches below the jugular notch. And this was for the same as the AP. And it says T7 for a PA. Now, I don't quite get why they're changing it that there, but it says for the AP, it's 3 inches below the jugular notch, 3 inches below the jugular notch. I guess we could say that, but jugular notch, that's not going to hit T7, but I think that's what they're trying to tell us is 3 inches below here is going to hit, I guess it is T7. It's still hitting at the nipple line. Instead of saying nipple line, 3 inches below the jugular notch still takes you to basically around T7. AP or PA projection obtained using the lateral decubitous position shows the change in fluid position and reveals any previously obscured pulmonary areas, or in the case of a suspected Pneumothorax, the presence of any free air. If you're looking for free air, it's side up. If you're looking for fluid in the lungs, it's side down. This is called an APPA decubitus, used for in place of a person not able to stand, but there's a suspicion that they may have some type of fluid. Let's see what we got next. Evaluation criteria. This is side up, so they were looking for, obviously, this is what? What's down here? This is all fluid. It's not air anymore. Remember, air is black. So we've got distinct side up, left side up. So he's got right pleural effusion. This one here, you see the black air up here, how black, and you see how it's got that straight line right there. It's leveled off. So this is a pneumothorax. He's got free air on the right side. So we had side up. We wasn't worried about this side down here because they were suspecting the pneumothorax to be on the right side. So side up for air, side down for fluid. This would be called a right lateral decubed. This is called a left lateral decubed. We name it by the side that it is down. Again, we mark them side up, right side up, left side up, but this is a right decubed chest x-ray. This is a left decubed chest x-ray, meaning that the left, they're laying on their right side here, they're laying on their left side here. So you're going to call it the opposite of what side is up. But we always put the little word up, either annotated or we use a BB showing that the patient side was up. So this right lateral decubed is used to demonstrate free air. This has got the, fluid. This has got fluid, tons of fluid. The left lateral decubed on this patient was used to demonstrate a pneumothorax on the right side. Let's see if is that in your book somewhere? I don't see these two images. I see one of them. I see that first image on page 125. All right, lateral, ventral, and dorsal decubed. This is the same idea as your AP and PA decubes that we just got finished doing, but look how the patient, he's either ventral or dorsal, and it can also be used for the same thing. And I am looking, this is on page 127. With the patient in a prone or supine position, elevate the thorax 2 to 3 inches on folded sheets. Again, they need to be elevated because what's going to happen with the fluid, it's going to all go to the back posterior part of the lungs. Same thing, we need to have 5 minutes before the exposure to allow the fluid and the air to rise or drop. Adjust the body in a true prone or supine position. Place the affected side against the vertical grid device and adjust it so that the top of the IR extends at the level of the thyroid cartilage. Second inspiration. Central ray is horizontal and centered to the IR. The central ray enters at the level of the mid-coronal, 3 to 4 inches, which again, T7, 3 to 4 inches below the jugular notch. The lateral projection of the decubitus position shows a change in the position of fluid and reveals pulmonary areas that are obscured by the fluid in standard projections. So this is a lateral, because we're doing a lateral side, lateral shot, the patient's being lateral. It is a decubed because we are using a vertical device and we're using a horizontal beam. It's ventral or dorsal. He's dorsal right now because that's the back, or he could be ventral. So at any rate, this one here is rarely done. I do know we do it at times when we're suspecting an abdominal aneurysm. That will show up real well on this type of projection. But other than that, this is a rarity. Normally, it's going to be the cubes that we just talked about, the AP and PA projection, right and left lateral decubitus when the patient's actually on their sides. Okay. So anyway, I'm going to end that one there. Let's see if we can close this one out. I hope this is working for you guys. I'm thinking ways that we can get this information across to you in smaller bites. I'll do one over the abdomen tomorrow, hopefully. If you have any questions, please let me know. We can do some WebEx time together. I'm here for you. I'm trying to be creative. If anyone has any ideas, please share them with me, and stay safe. And I'll be posting some more later. Thanks, guys. Take care. Bye bye.